Welcome to Oncology Morning Commute, a primer on B-cell targets in relapsed or refractory diffuse large B-cell lymphoma. Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from ADC Therapeutics America, Incorporated. In this podcast, Dr. Paolo Cami and Dr. Juan Alderuccio discuss relapsed or refractory diffuse large B-cell lymphoma. How is refractory disease defined? And what is the role of the new antibody-based therapies in relapsed or refractory disease? Information about the faculty and disclosures can be found at morningcommutepodcast.com/bcell1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Cami is on staff in the Department of Hematology and Oncology at the Cleveland Clinic in Cleveland, Ohio. Dr. Alderuccio is an associate professor in the Department of Medicine at the Sylvester Comprehensive Cancer Center in Miami, Florida. I am your host, Candace Hoffman. Dr. Cami will begin our discussion.
Dr. Alderuccio, thank you for joining me on this podcast to discuss relapsed or refractory diffuse large B-cell lymphoma. While diffuse large B-cell lymphoma can be cured in the majority of patients, 30 to 40% of patients can relapse or be refractory to the initial line of therapy. Tell me, how do you approach diagnosing a relapse or refractory state, and how do you define this patient population?
Hi, Dr. Cami, thank you for having me today here with you. So I think important definitions of relapse and refractory diffuse large B-cell lymphoma. I try to obtain this definition from the CAR-T trials. So the definition of refractory diffuse large B-cell lymphoma are those of patients with progression of disease as best response, or those with stable disease after at least 4 cycles of frontline chemotherapy, or those patients that achieve a partial response with a positive biopsy. Regarding the definition of relapse, diffuse large B-cell lymphoma are those patients that initially achieve a complete response, but were followed with a positive biopsy. And I think it's important the time frame between the achieving of CR and relapse, especially because those patients that relapse within 12 months, there is significant data supporting the use of CAR-T cells in this setting.
Yeah, I think that's kind of probably what has really changed a little bit the landscape of managing patients who have their disease either persist after R-CHOP, that we would consider refractory, or those who relapse early, right? I think it's a distinction that, although we understood that it affected prognosis in the past, we didn't really have a significant action plan that was different to other patients who had a late relapse. We just knew they were going to do a little bit worse or worse than people who had a late relapse. I think that the point that I tend to make in general in terms of defining relapse or refractory state is, for me, I'm somewhat particular about at least the first time the disease returns. I'd like to confirm it with a biopsy. I think just a PET scan, although I think in the majority of cases we can't confirm with a biopsy, is the point that I make to my patients. Most of these patients are supposed to respond and respond well to R-CHOP or initial chemotherapy. And if the patient is not behaving like they should, meaning respond to the treatment, we should be confirming that with a biopsy, either to ensure that we're just having the right diagnosis, to confirm that it's truly what we're seeing on the PET scan corresponds to refractory or relapse disease, and sometimes we even get additional biologic insight. I think probably over time we'll understand whether there's certain markers, whether we weren't able to get FISH status or other immunohistochemical markers, understanding in the future whether the 19 is going to be expressed. I think it's in the majority of cases, or other targets for immunotherapies or targeted therapies. So I think the definition of relapse state also comes with the fact that I think, how do we confirm the relapse state with a biopsy? What do you think about the 12-month? I mean, one of the things that I've been struggling with is it's really it's an arbitrary way of trying to define chemosensitivity, correct? I think it's just trying to find a group of patients who are truly chemorefractory. I'm sure there's a few patients that are, that relapse early that probably are going to be potentially sensitive to salvage chemo, but we're kind of batching them all as chemorefractory.
Yeah, no, I agree. I think it was an arbitrary time point, the 12 months, but it was how the trials were designed. So, but I agree with you that some of these patients may still be benefit that can be selected for salvage chemotherapy, follow eventually by transplant. I think what is key is if the patient progress during frontline chemotherapy, that patient, I think the probability is that this patient will respond to platinum-based chemo, it's low. So I think that's the population that most likely I would select for a CAR T type of approach. However, a patient that achieve a CR and subsequently relapsed, probably if a patient relapsed, I would say after 6 months, 9 months, that patient may be suitable for platinum-based chemo. And I think it's worth to eventually, if the patient has a good performance status and is a candidate for autologous stem cell transplant, to start that type of approach with salvage chemo and eventually transplant those patients.
I think particularly looking at the data, I mean, first of all, we'll talk a little bit further about the results in the relapse or refractory setting for CAR T, but I think it's arbitrary, right? I think you have to find some way of finding your chemo-refractory or chemo-insensitive patients, and it's probably as good as we have right now. There's not really good biologic markers for who's going to respond to cisplatin and go into a very nice deep CR that we can take them to an auto transplant. So I think that in that sense, it's probably that's what we have right now. I wish we could have a test to say, well, maybe we could use some chemotherapy, even debulk it before CAR Ts. I think moving on a little bit towards what options we have for patients. I think we've already touched a little bit that for refractory patients we have CAR T, or for early relapse we have CAR Ts as well. How do you approach them in terms of your choice of CAR T? Your choice of salvage regimen, if you're going to use something, how is your bridging approach? Kind of once you have a patient that is relapsed, what is the decision tree you follow?
So if the decision is to proceed with autologous stem cell transplant, or at least attempt that approach, I usually use platinum-based chemotherapy that is based on what was the frontline therapy. If the patient was treated with R-CHOP, is RICE, but if the patient was treated with frontline Epo-CAR, I usually try to use RD-HAP or RD-HAX, as etoposide was already included in the frontline setting. If the patient, the decision is to move in the direction of CAR T, I try to avoid bendamustine before T-cell collection for the risk of the lymphodepletion. So we depend what is the disease burden and the symptoms of the patient. In the SUMA-7, the only salvage therapy was glucocorticoids. Mm-hmm. So that's sometimes it's uncommon that these patients can be without treatment or only with steroids for 3-4 weeks until the product is back. So sometimes what I do in those settings is giving polatuzumab or rituximab to try to address the symptoms until the T-cell collection is performed, and subsequently until the CAR T product is ready, continue with bendamustine, rituximab, and polatuzumab until we're able to infuse the CAR Ts.
Yeah, I think it's a somewhat difficult decision. It's easy when you're getting the salvage chemotherapy, getting them ready for an auto. I think it was, we're moving from this world where everything was very linear to having a very kind of wide spectrum of choices. My approach is very similar to yours. I think in general, moved over time towards ICE as the main platinum-based chemotherapy. I've used DHAP in the past, not a lot of DHACs, and I used to use quite a bit of gemcitabine, cisplatin, dexamethasone with rituximab, kind of more like the Canadian approach, maybe because we're so close to them, in part because it's an outpatient regimen, but I think you have to be careful always with cisplatin. Cisplatin can be something that, particularly if these patients were more advanced stage, that to tolerate with more difficulty, and the nausea, dehydration, renal failure can be a price to pay. Sometimes that can prevent you from getting them to transplant.
I completely agree at that point. Sometimes what we do is to split the dose of cisplatin and give further hydration, and after the patient goes home, is discharged from the hospital, schedule as outpatient a few times a week hydration. Yeah, I agree. The issue with cisplatin is the kidney toxicity and electrolytes abnormalities.
And I think, and then the approach for CAR Ts is, the debulking versus bridging, right? I think I agree. I think most of us are avoiding bendamustine. I find it interesting that polatuzumab single agent or with rituximab has gained so much traction when I think the approval is somewhat not included as a single agent, but I think we've used that. I do think that we haven't explored as a community yet how much importance might tumor bulk have and tumor debulking prior to collection or prior to CAR T infusion have on the results. But my suspicion is that you have somebody with minimal amounts of tumor would have better response to CARs. And I think that will be maybe a component of important research in the near future.
I agree. And also maybe we are a little bit extrapolating data from mantle cell that we know that a prior bendamustine-based regimen affect the outcome of CAR T patients treated with this approach. So we definitely need more data in this.
No, I agree with you. I think bendamustine has T lymphotoxicity that is pretty well known in both in mantle as well as in follicular. The results, at least on the upfront trials, I think it's known that it will affect your T cell composition, populations, and affects probably the quality of the product. I think the question is polatuzumab single agent or the right thing to do for bridging prior to collection or not? I think the other point that I think you highlight a little bit is there's a group of patients who are underserved by the delay, right? It's just the patient that is rapidly progressing. And I think we know the patient that needs rapid treatment in the front line, and we've seen that at least in our local data, the patient that is needing treatment quickly in the second line, is a patient who has poor prognosis, is rapidly progressing, and that's a patient that we worry about. And I'm afraid that, by not being able to get them to CAR Ts, this is a group that is still uncovered by the new developments, right? I think it's a patient that we're not serving well yet by CAR Ts, and it's a patient that for whom maybe a cycle of something like ICE could potentially help get them ready for CARs, right?
Yeah, no, I agree. It's important that there are some studies demonstrate that elevated LDH performance status have been associated factors with a worse outcome after CAR T. So probably those are patients that, if available, a clinical trial will be the best option in this setting, if this would be available.
How about what considerations do you do for getting somebody to auto? I think it's fairly well defined, the population of patients that you think are transplant eligible. And then we'll talk about the CAR T eligibility, which we think is somewhat wider, right?
Yeah, I agree. Usually it's based on the left ventricle, the cardiac function, that the patient should have an acceptable cardiac function, acceptable renal function, pulmonary function, and also acceptable liver function test. Regarding the age, we have been doing a little bit more doing in older patients, 70, 75 years old. And as you mentioned, in CAR T trials, they include patients in the early 80s. So I think there is a little bit more data to use in older patients CAR T. That doesn't seem to be a factor.
Yeah, I think organ function is kind of your main determinant. I think it's continued to impress as I get older, as my parents get older, what the definition of advanced stages. I think
Yeah.
we all experience that.
Yeah, no, I agree. I think probably it's more a performance status rather than a.
And I think organ reserve is really kind of getting better. People are getting fitter into their 70s. I've had, a few patients over 75 that we've done a transplant, and they've actually done fairly okay. I do worry there are patients that sometimes we forget they're not easy to collect. They don't their marrow reserve is just not excellent, particularly after a couple of rounds of chemotherapy. Some of these patients tend to either require a couple of rounds of collection, almost always with Plerixafor, and sometimes they just don't mobilize well. And then I think they're slow to improve unless they're very fit after a transplant. I'm definitely for CAR T. I think that it's a different paradigm than for auto transplant, right? I think if they do well, they don't have any acute complication. You can do this in an 80-year-old, particularly with drugs, with products with 4-1BB, where the risk is for costimulatory signal, where the risk of having adverse events is probably a little bit better, at least in terms of the acute CRS. Do you use those parameters to choose your CAR T product, or you use something that is institution mandated or kind of preferred?
Yeah, no, we use those markers that you just mentioned, but the truth is that this is more a choice from the transplant group that are specifically who at our institution they do the CAR Ts. So they at the end they are the ones who select the CAR T product.
Okay. So in general, it's something that is off of your hands to see what they choose.
Yeah.
So there's every institution does it somewhat different, correct? I think our choice of CAR T varies depending on our choice or who makes the choice. Here is the lymphoma docs that actually do the treatment. Certainly there's not just CAR Ts, there's other drugs, and I think there's other agents that are coming now in the third line. I think that's kind of expanded to, most of them are antibody-based. I think with both tafasitamab, lenalidomide, loncastuximab. We talked a little bit about polatuzumab. We'll talk a little bit more as well. I think all those things are expanding to people who are either not going to get CAR Ts. CAR Ts dominate, kind of take a lot of the air in the room. But I think there's certainly things that we can consider. Which kind of patient do you think that kind of you prefer or consider CAR T ineligible, or you prefer to use one of these drugs in the third line?
I think would be based on the fitness of the patient and the organ function. That is going to be how we proceed with, and the definitions of transplant ineligible or basically. So if a patient fit has a appropriate an organ function and the patient has a appropriate performance status, I think that the patient is eligible for this type of cellular products. That's what I usually try to keep in my mind and to select one therapy over the other.
Yeah, I'm on the same boat. I think that's somewhat, it makes it, I mean, these drugs, as we said, their eligibility is much wider for CAR Ts than for transplant. And I think that the group of people who cannot get CAR Ts is not extremely large. Although we have to always mention access is definitely an issue, right? And I think patients for whom staying a month away from home, or for whom travel to the transplant center, or for whom cost to insurance cover is an issue. I think these drugs kind of start becoming more attractive. I've had a couple patients for second line therapy, tafasitamab, lenalidomide, for whom, although the visits are frequent, they don't require them to stay in the hospital. Certainly something I use for older patients, thinking that that's probably where that combination performs best. And people who are not refractory, who do to first line therapy, for whom a response to tafa-len could potentially give them quite a bit of time of long-lasting response, although with long-lasting treatment too.
Yeah, no, I agree. And both of us, we work at centers that we have these capabilities and we are able to use CAR T, but there are patients that don't have this access. So definitely off-the-shelf type of therapies are eventually appropriate in patients that they don't have the access to these cellular products.
Yeah, we're definitely spoiled. I think that's where, and that's how sometimes I say we tend to use a little bit less these agents less than we did in trial. Mm-hmm. I think, particularly for me, I think we continue to use Lonca, and give it, but these are for patients in the third line, for whom neuropathy is an issue. We start considering loncastuximab, or for whom travel to our medical center is complicated because of distance. We have people coming from out of state. So once every 3-week infusion is also an option. Same as for Pola-BR, right? I think in third line, that may change if frontline Pola-R-CHOP is adopted significantly, but I think Pola-BR is a infrequent visit, scheduled a little bit more than others, but every 3 weeks is just 2 days. So I think that those are the things that I start to consider, the tolerability, safety, and schedule as well. I think one of the things we forget with Tafalen is that the schedule is pretty intense those first 8 weeks.
Yeah. And then, yes, and those patients that achieve at least a stable disease should subsequently continue tafasitamab single agent. So yeah, there are all these factors need to be evaluated at the time of decision and needs to be extensively discussed with the patient.
Yeah. Well, great. That has been a very informative discussion. I hope we continue to touch base on these drugs through the following series.
Yeah.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/bcell1. Look for all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.